Hello, it's Dr. A, and we're going to cover immune system diseases for clinical chemistry. All right. So, and this is important, I would say, really because of the rise in the amount of autoimmune diseases that we're seeing as a chronic disease. So, there are three major categories of immune diseases. There's allergic immune deficiencies and then autoimmune diseases, which are really overreactions of the immune system. And then you can classify them as inherited versus acquired for the immune deficiencies. So an inherited immune deficiency would be a Gammaglobulin Anemia of some sort is inherited. So like a lack of capacity to produce one of the gamma globulins, so IgG, IgA, IgM, or something like that. Where as the acquired immune deficiencies would be examples of HIV leading to AIDS. That would be an acquired immune deficiency. But if you will, chemo treatment could be kind of a type of acquired immune deficiency. It's this deficiency due to the chemo. And then some are inherited with an environmental trigger. And this is where autoimmune diseases and allergies come in. And so they're inherited because they tend to run in families. There is a genetic component to it, especially usually tied to the HLA antigen types and stuff. And, for an allergy, there has to be, for allergies, especially environmental trigger, which could be, we might think of an environment like pollen or grass or whatever, but it also can be food or something. So something coming into the body that's causing an overreaction that's an allergy. And if you will, with the autoimmune diseases, if a person is prone to get an autoimmune disease, then and they have one, then they're actually more prone to getting others. So there's definitely, because they are all like overreactions of the immune system, there's definitely factors in common there, and they do tend to also kind of run in families. So there's a genetic component there. But one of the things that I have heard several times already in the autoimmune world is that, if you will, genetics load the gun and the environment pulls the trigger. So just because genetically it might run in a family doesn't mean that everyone will get it. It kind of depends on the lifestyle and then the environment around the person. It could be things like if they live in an urban area, exposure to pollution and smog and stuff like that, or if they live in a rural area, what if they live in an area where they're spraying a lot of pesticides on the crops and stuff. And so those could be other environmental type of triggers and exposures that could cause one to go down an autoimmune path. It can be infections can trigger it. It can also be things like heavy metal toxicities. There's just such a variety of things that can trigger an autoimmune reaction, or that can make one more prone to. Okay, so first, I want you to think, what's an example of allergy? What can people be allergic to? Okay. And then next, I want you to think of let's be an autoimmune disease. What is autoimmune disease? What is an example of autoimmune disease? Okay, so let's first talk about the normal immune system. So the normal immune system response is a slower, specific, and long-lived response, meaning that if a person is exposed to a pathogen, so let's go with group A strep, and the first time that they get it, it's going to take a few days for the full immune reaction to take place, for antibodies to be generated, and the antibody titers to rise appropriately. Okay, and the antibodies that are created are going to be very specific, going to be specific to the group A strep. And then ideally what happens is that you keep those, and then with subsequent exposure, the body's more efficient at fighting off the group A strep. And this is especially seen these long-lived responses with viral diseases and stuff where usually you only get it once. The normal immune system response works with inflammation to control the pathogen. And the main function of the immune system is to differentiate self from non-self. So know which cells are there and are normal and which cells are pathogens and need to be destroyed. It is composed of the primary and secondary lymphoid organs. So your primary ones are going to be your thymus and your bone marrow. They actually are the ones that are producing the lymphocytes, whereas really it's the bone marrow produces the lymphocytes, the thymus does mature it up. But basically, if you will, they both produce mature lymphocytes, if you want to be more specific. Your secondary lymphoid organs are your lymph nodes, your spleen, your appendix, tonsils, mucosal associated lymphoid tissues, and all that, and they store lymphocytes. So if you will, the primary lymphoid organs is where the lymphocytes go to school to become lymphocytes. Your T cells go to the thymus, the B cells stay in the bone marrow, and they grow up and learn how to do their job, and then they all go get stationed at their respective job stations, which are going to be the secondary lymphoid organs. And the primary and secondary lymphoid organs are connected together via the blood and lymphatic systems. All right, so your T cells do originate in the thymus, even though the pre-T cells, the precursor lymphocyte, are made in the bone marrow and then sent to the thymus. In the thymus, they grow up to become the fully functioning T cells. They can become T helper cells or cytotoxic T cells. So these each have a different role in the immune system response. And T cells generally are involved in what we call cell-mediated immunity, meaning there are cells that are looking for virally infected cells, cancer cells, and normal cells in the bone marrow, and their job is going to be to destroy those cells. Now, the T helper cells are actually more like coordinators, or like generals of the immune system army, and they coordinate the response between the cytotoxic T cells, the B cells, and the macrophages. The B cells originate in the bone marrow. They are antibody producers. They tend to look a little bit different than the T cells. And the majority of the cells you'll see in blood are going to be T cells. But some of them are going to be B cells. And then if they've been activated into plasma cells, they'll have that kind of fried egg, higher plasma to nucleus ratio here, because all of this is going to be full of endoplasmic reticulum producing antibodies. So these guys produce all your antibodies, and they are responsible for humoral immunity, or which is really what you refer to as when you talk about the production of antibodies. And so we have innate immunity versus acquired immunity. So innate immunity has no memory; it works the same way every time, and the response is the same each time the antigen is encountered. It also, I would say, no matter the antigen. So it can be the same whether it's a virus or bacteria, etc. So these, part of the innate immune system would be an intact skin barrier, intact mucous membranes, but it can also be reflexes like sneezing and vomiting, but they can be, on a chemical level, activation of the complement system, macrophages, which they just, they get everything that just doesn't belong, kind of indiscriminate. Natural killer cells are also kind of an innate version of your cytotoxic T cells. There's even a certain amount of innate IgM that helps protect. And then acquired immunity has memory and is very specific, has specificity. So it is the response is to usually a specific pathogen, specific antigen on that pathogen. And the immune system response becomes stronger with each successive encounter with that antigen, to the point that on some, for example, with chickenpox, if a person that's had chickenpox in their childhood, if they're ever exposed again, they'll usually not even any symptoms, you don't even know. The acquired immunity is usually humoral immunity. So B cells produces antibodies, and those antibodies are going to be IgM, IgG, IgA, IgE, and IgD, depending, of course, on the need of the body. Cell-mediated immunity, which also, again, is specific and has memory, and this is going to be your cytotoxic T cells that destroy virally infected cells and cancer cells. I like this little diagram because it does a really good job of kind of comparing and contrasting humoral immunity versus cell-mediated. So for humoral immunity, the microbe are going to be extracellular, whereas with cell-mediated, they are intracellular. So they can be either phagocytosed microbes in a macrophage or intracellular microbes like viruses, that are replicating within a skin cell or an infected cell, sorry, not specifically skin, it could be any kind of cell, but a body cell that's hosting them. The responding lymphocytes for extracellular microbes and humoral immunity is going to be the B lymphocytes, making antibody. The response is to make antibodies that are going to coat the extracellular microbe and make it easier to eliminate, makes it easier for the macrophage to phagocytose them, and on some of them for complement to be activated and things like that. So in cell-mediated immunity, the response involves the T helper lymphocytes and the cytotoxic T lymphocytes. And the T helper communicates with the activated macrophage and then produces cytokines and things. And then what happens to the T helper is then, depending on the pathogen, it will activate either more B lymphocytes or some cytotoxic T lymphocytes, and it coordinates the immune response. Intracellular microbes will trigger cytotoxic T lymphocyte activation, and they will destroy that body cell that's infected with the viruses. How does it know it's infected? Because as that body cell produces the viral particles, it will actually put some of those viral particles in the cell membrane, and that'll identify it as basically being infected. Okay, quick poll question. Which one of these produces antibodies, B, T, or macrophages? So some more about the basic immune mechanisms. So again, the point of the immune system is to protect against non-self tissues and cells. Once an organism invades the body, it is engulfed by macrophages or dendritic cells, depending on the location. And once it's engulfed, it's presented to the T helper cells. Again, these coordinate the response. So it's basically the macrophage saying, hey, look, I found this. Do we need to react to it? T helper cell is going to look at it and say, yeah, we do, or no, we don't. The T helper cells then activates and signals B cells, the T killer cells or the cytotoxic T cells, and your regulatory T cells. So these we haven't mentioned this as a subclassification of the T cells, but these are really important. So regulatory T cells, their job is, after basically the threat has been neutralized, they need to just calm all the troops down and turn down that immune system response. And in autoimmune diseases, there's often lack of activity or lack of number in these regulatory T cells. And interestingly, a lot of the regulatory T cells to operate ideally and to be activated and do their job, they need vitamin D, some vitamin A, and a lot of people with autoimmune diseases are low in vitamin D. If you can regulate their vitamin D levels back up to normal, a lot of times these guys can kick up appropriately and their autoantibody levels will drop significantly. The B cells then will, once they've been activated by the T helper cells, will become plasma cells, which are basically little antibody factories, and then produce a bunch of antibodies. The T killer cells, when they were activated by the T cells, go do their job and destroy all the abnormal cells. And then the regulatory T cells will stop the immune system response at the appropriate time when the threat has been neutralized. So any disruption in this process can lead to immune deficiency, and the disruption will determine the type of immune deficiency. Or, of course, like I said, if the regulatory T cells aren't doing their job, then there's an overactive immune system. Hypersensitivity. So this is an immune response that leads to tissue damage. It can be categorized by either antigen or the mechanism. So if you categorize it by the antigen, it's either an allergy, autoimmunity, or alloimmunity. So allergy would be, your body reacting to allergens, which are really non-threatening. There's nothing wrong with pollen. Pollen's not a pathogen. It's not going to invade your body, cause infection, but your body reacts to it. All right. So if you have allergy, it'll be allergy. Autoimmunity is, again, immune system response kind of gone haywire, the body attacking itself. Alloimmunity would be your body reacting to a transplanted organ or transplanted tissue, as it really kind of should, but you hope that it's matched appropriately so that the immune system of the recipient can be fooled into thinking that the donor tissue is the same as its own. You can also classify hypersensitivity by mechanism. So you have type 1, type 2, type 3, and type 4. So type 1 is IgE mediated. This is typically what we think of when we think of allergies. We're going to look at all of these. Type 2 is tissue specific. This is more like ABO incompatibilities. Type 3 is going to be immune complex mediated. Some of your immune system immune diseases, so autoimmune diseases are there, like lupus. And type 4 is going to be cell mediated and usually delayed. These are more like delayed rejection of transplanted organs, but also like your delayed hypersensitivities to things like poison ivy, poison oak. All right, so let's look some more at hypersensitivity. So first of all, you have to be sensitized to an antigen prior to a reaction. This is a fancy way of saying that you're never going to be allergic to something the first time your body encounters it. So the first time you're stung by a bee, you won't be allergic to it. You won't have an allergic reaction to it. But now once your body sees it, it may decide that it doesn't like it. And then if you get stung again, you get a second sting, then you might have an allergic reaction. There are immediate hypersensitivity reactions. They're usually type 1 reactions, and they happen in minutes to hours and can lead to anaphylaxis. So anaphylaxis systemically, you will see itching, erythema, which is redness, headache, vomiting, cramps, diarrhea, and breathing difficulties. It can be enclosed airway, can become really life-threatening. Cutaneously, you will see hives that develop, and anaphylaxis always requires intervention, usually in the form of an EpiPen and then a visit to the ER. Delayed hypersensitivity reactions take hours to days to happen. So again, a typical one that most people can relate to is exposure to poison ivy or poison oak, where you don't really see the rash until 24, almost 48 hours later. And once you're sensitized to an allergen, that sensitization can be long-lived, so it can be more than 10 years due to immunologic memory. Usually meaning if you're allergic to something, you're probably going to be allergic to it for the rest of your life, although there are instances of people growing out of certain allergies as they transition from childhood to adulthood. The severity of the hypersensitivity reaction will depend on a variety of factors. The mode of transmission and the dose of the antigens are two of the biggest factors. So the mode of transmission would be, was it a stung? Did you get stung by a bee? Is it something that contacted your skin? Is it something you ingested? Is it something you inhaled? Is it a drug you were given, IV, etc.? And then the dose is, of course, how much should you get? So some of the modes of transmission, again, respiratory, GI, circulatory, or skin, those are kind of the 4 biggies. Okay, so for type 1 hypersensitivity, it is always an immediate hypersensitivity, and which the IgE is involved and binds to mast cell receptors. So this is really true allergies. So if a person is allergic to peanuts, allergic to shellfish, allergic to strawberries, allergic to wheat, for example, because I'm allergic to wheat. They will have, you can measure, they will have IgE specific to that antigen, specific to peanuts, specific to wheat, specific to strawberries, etc. And they will have a reaction every time they're exposed to it. So the antigen contact is usually low dose via mucous membranes, either in the respiratory or the GI tract. So something that's breathed in, like a grass pollen, something like that, or ingested, and then it happened, then it would be in the GI tract. And so they are then preformed Ig antibodies that will elicit an immediate response, and the response can occur in seconds or minutes. And it causes the release of histamine, proteases, and chemotactic factors. The histamines contract the bronchial muscles, make it more difficult to breathe, possibly closing the airway. It increases vascular permeability, meaning things are going to leak out of the blood vessels and cause swelling. and dilates the blood vessels, so there'll be also more lower blood pressure, but also increased blood supply to certain areas. This can be life-threatening. You can get complete loss of breathing. You can get major circulatory collapse and stuff. Some of the manifestations include circulatory collapse in bee stings, respiratory. Again, for asthma, that could be like peanut allergies and things like that, where they have difficulty breathing. GI manifestations, so the cramping, nausea, vomiting, diarrhea, but also GI thing could also cause skin reactions too, and in the reactions, the manifestation in the skin was immediate, like rashes and hives and stuff in the skin. And so just if you think of a typical like hay fever type of allergic reaction, if somebody, for example, is allergic to grass or allergic to pollen, so as soon as they're breathing in, as soon as they're exposed to the antigen, allergen, within 30 minutes, they're going to have all the typical signs and symptoms, even if it's not anaphylaxis. So they could all of a sudden, they have a runny nose, they're sneezing, watery eyes, maybe they get a headache or something like that. But it happens really quickly after exposure to the trigger. So your type 2 hypersensitivity is a cytotoxic hypersensitivity. So this one is triggered by the binding of IgG or IgM to tissue-specific antigens on cells or external antigens on tissues. So again, this is your body recognizing something foreign as foreign. So again, ABO incompatibility is going to be the main one we can think of. Hemolytic disease in the newborn is another one. There are 5 mechanisms by which type 2 hypersensitivity occurs. So ABO and hemolytic disease of the newborn are going to be activation of the classical complement pathways. Phagocytosis by macrophages is autoimmune thrombocytic purpura. Neutrophil damage is good Pasture. That's how the tissue gets damaged. Natural killer cell activation is usually triggered by parasites, and antibody binding to cell causing malfunction is Graves' disease. So on this note here, so what happens with Graves' disease is the antibody is binding on the TSH receptor. The thyroid is reading it as TSH binding, and therefore it releases more thyroid hormone, and so that's why Graves' disease is a hyperthyroid disease, is the thyroid is producing too much thyroid hormone, but it's because the antibody is basically mimicking the response of TSH binding to that receptor. Your type 3 hypersensitivities are immune complex hypersensitivities. So immune complexes are antigen antibody complexes, and they deposit in tissue, so they're floating around in the blood and then get stuck in some tissues. It is not tissue specific, so these tend to be systemic reactions, and they're associated with systemic autoimmune diseases like rheumatoid arthritis and post-streptococcal glomerulonephritis, where these antigen antibody complexes can deposit within capillaries and then cause it attracts neutrophils, and then it causes damage in the capillaries there. And this can be in any tissue, anywhere in the body. And then your type 4 hypersensitivities are delayed, so they can take 48 to 72 hours to fully express themselves. They're always mediated by T lymphocytes. Their natural killer cells can directly attack the cells. If not, it's going to be the cytotoxic T lymphocytes. Contact dermatitis and graft rejections are the 2 main modes of action here of those two of type 4 hypersensitivity. So the poison ivy would be a contact dermatitis. It's the oil, the visceral oil on the leaf that causes the contact dermatitis. But some people can have contact dermatitis to certain metals like nickel. And of course, graft rejection is, your body just seeing that this is foreign and attacking it, but it does take a little bit, and so it's delayed. So it can also be associated with autoimmune mechanisms. So this can be the mechanism also behind RA, but behind Hashimoto's and type 1 diabetes. So in Hashimoto's, the antibodies are to the thyroid peroxidase and thyroglobulin. Hashimoto's is a hypothyroid type of autoimmune reaction, so opposite of Graves. Type 1 diabetes, the beta cells, the islets of Langerhans that produce insulin get destroyed by the autoimmune system. And so there's a lot of overlaps between hypersensitivity and autoimmune diseases. So a few quiz questions just to check your understanding. Which hypersensitivity is RA an example of? There are two possible answers for that one. Which hypersensitivity is a peanut allergy an example of? Again, the answer is always 1, 2, 3, or 4. Which hypersensitivity is contact dermatitis an example of? And which hypersensitivity is hemolytic disease of the newborn an example of? So there you go. Next is allergies. So they are allergies are type 1 hypersensitivity reactions. But again, your type 2, 3, and 4 can be related and can produce allergic type reactions. And so this is also an interesting thing. For example, within food allergies, some people can have true allergies, meaning IgE, and it's going to mess with their breathing. But then some people really have what we call food sensitivities, and it's IgG mediated, and it produces more of maybe some GI distress, but joint pain and headaches and something like that. So in allergies, in true allergies though, you have high levels of IgE that are produced. The symptoms can range anywhere from troublesome to anaphylaxis. So troublesome would be, dang it, you have a runny nose and watery eyes now and you got to go take some Benadryl, to anaphylaxis and oh my goodness, you can't breathe, right? So the lab tests that can be done, you can check for IgE levels. Although total IgE levels are not very useful because it doesn't tell you what you're reacting to, and therefore then usually, so you have to have a panel and usually a list of suspects. They can start with some of the most common ones, but your doctor, if it's working with you, may have to kind of ferret out and ask for specific things and test your IgE against those things. And this can be done on the blood. You don't have to specifically do the skin prick test, which I think the blood level's a little bit more accurate there. There are serum tests available for specific allergens. It can be tested for IgE or IgG allergens. So again, you can check for if you have IgE to wheat or IgG to wheat. If you have IgG to wheat, you'll have more what we call a gluten intolerance. If you have IgE to wheat, you really have a true wheat allergy. And so, again, these can be checked for a lot of the common food allergens that people react to. The will and flare reaction is the skin testing. It has to be done by an allergist. This is often done for allergies to different grasses and pollens and cockroaches and things like that. You could technically do see if you're allergic to certain food things that way too, but usually it's the blood testing has become more standard here. Autoimmune diseases, the body loses the ability to differentiate self from non-self and attacks self-antigens because it thinks that they are foreign. The theory behind this is antigenic mimicry. So a hapten of the pathogen binds to a self-antigen, and then you have autoreactive lymphocytes. So basically the lymphocytes are mistaking the tissue for the antigen. I'll give you an example with Hashimoto's. So did you know that there are proteins on the thyroid that, so obviously thyroglobulin and thyroperoxidase, because that's the autoantibodies in Hashimoto's, that look a lot like the protein in gluten, and so an area of the gluten protein and an area of the casein protein in dairy. And so it's very possible that it's, an autoimmune reaction. It's a reaction to gluten that is confusing the thyroid for gluten, and so it's attacking the thyroid and causing Hashimoto's. And a lot of those patients that have Hashimoto's, if you put them on a gluten-free and dairy-free diet, they do a lot better. And again, with the autoreactive lymphocytes, these should be suppressed and turned off by your Treg cells, and if you don't have enough or they're not active enough, the T regulatory cells, then will not do their job, and those autoreactive lymphocytes will hang around and cause problems and breakdown of the tissue, and then you will see the effects of that depending on the autoimmune disease, so depending on the tissue that's been targeted. So let's look at a few of them. Systemic lupus erythematosus, or also referred to as lupus or SLE. It is a chronic inflammatory disease. The antibodies are produced with several self-antigens, such as nucleic acids, red cells, coac proteins, phospholipids, etc. One of the theories behind that is we need to be better. Sometimes we've lost the capacity for autophagy, meaning clearing, we're always replacing cells, but clearing the debris from the dead cells. And if these hang out too long, then you can make antibodies to DNA and cell membranes and stuff, which are not normally, found loose, pieces of it found loose floating around. But you have to be good. Your immune system has to be good at clearing the debris and the damaged stuff from just regular wear and tear. So in lupus, you can have a mix of type 2 and type 3 hypersensitivity reactions. And the symptoms are fever, joint pain, a butterfly rash across the face, malaise, fatigue, anemia, and cardiovascular diseases. And the butterfly rash across the face is where it gets the lupus name from. So if you're not familiar with the Mardi Gras mask, which is basically it's what they call a wolf mask. It just wraps around the eyes and goes like that, right? And that butterfly rash kind of mimics that, and so that's where the lupus name got its name from. So lab tests that you can be done for lupus are the ANA. You can also look for the presence of anti-SM antibodies, and this is diagnostic for the disease. And if the titers fall, the patient is responding to treatments. But ANA testing is difficult. It's hard to perform and to interpret correctly. And pattern recognition can be made confusing due to the presence of multiple antibodies in a mixed pattern. And many of the antibodies will produce a speckled pattern, and so it's hard to distinguish one autoimmune diseases from another. There are some ELISA assays that are available for specific antibodies, such as your anti-DNA, anti-SM, anti-SSA, anti-SSB, and anti-RNP, among others. Next one is rheumatoid arthritis. It is also chronic systemic inflammatory and autoimmune. The antibodies are against the synovial lining of the joints. It is progressive and disabling. The rheumatoid factor refers to the IgG and IgM against host tissue, against that synovial lining. And again, the disease mechanism is genetics plus an environmental trigger. And don't underestimate stress as an environmental trigger also. The diagnosis and lab tests for RA are going to be, we have the anti-CCP test. It's like a citrullinated protein. It's something that's actually in the joints. This is specific for rheumatoid arthritis and often used to diagnose the disease in its early stages. The rheumatoid factor can be done, but is not as specific because it can be found in a variety of other conditions, but it can be used to monitor the disease. Other monitors can include those that measure inflammation, such as the sed rate and the C-reactive protein. And then you can also do synovial fluid analysis to rule out other disease that can look alike, such as gout or pseudo-gout. But in gout for sure you would have crystals present, whereas in RA you would not. You might see white cells. So again, the susceptibility, so genes, so HLA genes combined with environmental factors such as certain infections, smoking, etc. You have enzyme modification because of the environmental factors, so you can have citrullination of that self-protein. Then you have failure of tolerance and unregular lymphocytes activation. Then gives you B and T cell responses to self-antigens, so it gives you autoantibodies, cytotoxic T cells, etc. And then that antigen or that tissue gets destroyed, and in this case is the synovial membrane of the joints. And it causes crushing of cartilage and bone and pain in the joints and loss of function. Sjogren's syndrome, the damage is to the exocrine glands, the glands that produce the saliva and tears, etc. It can be primary, so it'd be all by itself, or a secondary disease, as is can be associated with other autoimmune diseases, such as lupus, RA, or scleroderma. Again, because of the combination of all of these, the underlying fact that autoimmune diseases are genetic and environmental, oftentimes if a person has one, they can get another of the autoimmune diseases. There will be lymphocyte infiltrates in those exocrine glands. It will begin as localized, but can progress. The diagnosis lab test is going to be, again, through the ANA. The pattern-ish organ is speckled, like lupus. And so that can be indicative of either anti-SSA or anti-SSB, which we can test for now. But 70% of patients with Sjogren's have anti-SSA and 50% have anti-SSB. Pasture syndrome and then amyloidosis. So Pasture syndrome is a rare autoimmune disease. It results in bleeding in the kidneys and lungs. And it's a reaction, it's a type 2 hypersensitivity reaction to collagen type 4 that's found in the kidneys and the lungs. And the antibodies are the anti-GMB antibodies, so glomerular basement membrane maybe. So there you go, yeah, glomerular basement membrane, GMB. And so that causes this destruction of that and the capillaries and the bleeding. So, and amyloidosis is insoluble amyloid fibrils that deposit all over the body and tissue organs and cause dysfunction of those organ, and is diagnosis only by biopsy. So a little activity for my class to match up. So next we're moving on to immunodeficiencies. It's a defect of the self-defense portion of the immune system. If it's primary, it's due to a genetic mutation. If it's secondary, it's illness or aging. So illness such as, again, HIV would be an example. With Scottaldridge syndrome is a rare X-linked recessive disorder in which you'll see thrombocytopenia, immunodeficiency, eczema, and susceptibility for tumors and autoimmune diseases. The CBC results will show a low white count, low red count, and low platelets, and low levels of IgM and IgA. Ataxia telangiectasia is an autosomal recessive neurodegenerative disorders. The defect prevents the repair of DNA and the dilation of capillaries in the eyes, ears, necks, and extremities. So again, you need your eyes and your ears for balance, and your extremities, and probably also your neck for head position. And so it makes people really clumsy. And so just like this little dude here, it takes skill to trip over flat surfaces. They kind of tend to trip on their own feet, stumble, run into stuff. That's what ataxia means. Okay. And so the symptoms, therefore, are infections, malignancies, and ataxia, that clumsiness, and it is because you get cell death in the cerebellum, which coordinates your movement, so that's your smaller brain there, and it coordinates, how your mobility skills, if you will, and then the cerebrum and the immune system are all damaged. The diagnosis will show low immunoglobulin levels, positive tumor antigens, and you can do also genetic testing. DeGeorge syndrome is also known as congenital thymic aplasia. It affects T-cell maturation. There will be small or no thymus in parathyroid glands. So small or no thymus means the school for the T-cells is closed, right? The T-cells can't mature, right? And so you will see structural defects of the heart and facial abnormalities also with the DeGeorge syndrome, and the immune system is crippled. Bruton's Gammaglobulin. It's an X-linked Gammaglobulin, meaning no gamma globulin, or lack of production of gamma globulins. So the Bruton tyrosine kinase is necessary for the B cells precursors to mature. If you don't have any B cells that can mature, you don't have any antibodies. So the result is no plasma cells, therefore no antibodies, and therefore they are very susceptible to bacterial infections. And this starts really showing up around 6 months old, where there have been repeated infections and something's up. The CVID, or common variable immunodeficiency disease, is a collection of B-cell and immune globulin disorders. It is the most commonly diagnosed immunodeficiency. It shows up between 2 years of age and as late as even 20 to be diagnosed, and usually have a hypogammaglobulin anemia, meaning you're lacking one of the immunoglobulins. So it could be IgG is often low, but IgM or IgA could also be decreased. And so they could have low IgG or just low IgA. And they can have a normal number of B cells. It's just their capacity to produce a certain type of immunoglobulin is decreased. And then the severe combined immunodeficiency syndrome is definitely it's a spectrum of disorders, but the most severe is reticular dysgenesis. You have, in that one, there is no T cells, B cells, or phagocytic cells, so no immune system. And most will die in utero or soon after birth because they have no defense whatsoever. Most patients with SCID will lack lymphocytes, but have the other white cells. And then you can have complement deficiencies. So deficiencies of the classical and alternate pathways are very uncommon. The lectin pathway component deficiencies are most common. The consequence is going to be an increase in bacterial infections, and lab tests can be done for C3 and C4 levels. And possible also CH50, C1, C2, and C1Q, but those have to be done at a reference lab. A little case, I want you to see if you can guess which one might be his. So he's 8 months old. He's brought to the ER because he was listless, had fever and cough. This is his 4th respiratory infection in 4 months. The provider ordered a CBC, BNP, and UA. The results follow. Mostly the white count is low. Everything else is pretty unremarkable. If you look at all over, a little bit of ketones up there. Wild lab results are abnormal, and what other tests would you want to see, and what would be his diagnosis? So of those that are abnormal, like I said, the white cell was the really only thing that was remarkable, it being 2,000. That's 2. A white count of 2 is way too low. And what other tests would you? I would like to see his immunoglobulin levels. I'd like to see a serum protein electrophoresis to see is he lacking in IgG, IgA, or something like that, or if we can do total levels of those or something like that. But definitely want to investigate what's going on there. And which one of these would be the most probable. And although some of these are possible, like this one, I would probably go with Bruton's just because the fact that he's 8 months old, that usually shows up around 6 months of age, recurrent bacterial infections, etc., would make it such as I think that might be the answer for this case. The human immunodeficiency virus, or HIV, it is a retrovirus. It can cause a profound immune deficiency. It is transmitted via contaminated blood, needles and stuff, or sexually transmitted. And the problem with HIV, of course, is that it infects the T helper cells. So there's the CD4 cells. CD4 is a cell marker of the T helper cells. And since the T helper cells coordinate so much of the immune system, all phases of the immune system are affected because basically it's like the troops that have lost their general. There's no general in charge of the troops. And so the more T helper cells are destroyed, the worse the immune system is. It starts usually with an asymptomatic phase, and then eventually there's seroconversion. When initially infected with HIV, patients could have a flu-like illness. And obviously, with the initial infection, there won't be antibodies yet, so it takes a little while to seroconvert. So whenever there's exposure, unfortunately, to via something like rape, it is good to test for it at as soon as possible. But it's hopefully it's negative. But then again, if there was exposure, testing needs to be done again at 3 months and 6 months to make sure that it is still negative. And then if the person is infected with HIV and does not do the therapy that's recommended, they can eventually develop full-blown AIDS, which is when the CD4 count drops below a certain level where the immune system is completely crippled, and then you see opportunistic infections and cancers and stuff. The lab test, so HIV screening can be performed on serum or saliva. The screening tests only detect HIV antibodies, so they cannot detect early disease or early exposure. But now the 4th generation HIV assays from Abbott Diagnostics combine antibody testing with a P24 antigen testing. So again, when you antigen test, you're looking for the viral particles themselves. And so that P24 antigen is the first HIV marker that can be detectable after infection. It is available as an immunoassay test. The previous CDC algorithm used the HIV Western blot to confirm, but that was changed in 2015. And now with this combo of antigen antibody assay, they can just do a viral load to confirm diagnosis. So signs and symptoms of AIDS are going to be meningitis, encephalitis, AIDS dementia. In the mouth, there's going to be herpes breakouts and thrush, lymphadenopathy in the lymph nodes, tumors like lymphomas, nephropathy, AIDS nephropathy, Kaposi sarcoma on the skin, dermatitis, folliculitis, and impetigo, colitis, proctitis, small malabsorption in the small intestine, and pneumonias in the lung. Next, we have monoclonal and polyclonal gammopathies. These are disorders of B cells, either producing too much of one type of antibodies or too much of all of them. The monoclonal is simply one clone producing excess immune globulins. So multiple myeloma and Waldenstrom's macroglobulin anemia are 2 examples of monoclonal gammopathies. And the spike on immune electrophoresis will, protein electrophoresis will have to show a really sharp peak on one, in just the area of one of the immune globulins. The polyclonal gammopathies show elevated levels of all immune globulins and are more typical of autoimmune diseases like RA and systemic lupus erythematosus. And of course, the serum protein electrophoresis can differentiate between a monoclonal gammopathy and a polyclonal one. So again, with a monoclonal one, you'll have more of a sharp spike. Polyclonal, you'll more have a elevated just bump in the gamma globulin region. So there you go. So that wraps it up for our immune system disease. If you have any questions, you can email them to me if you're a student, or you can drop it in the comments.